I'm Sandip Nandhra. I'm one of the vascular surgeons in Freeman and Newcastle, and I'm half academic. I am employed by the university for my job. And I suppose what I'm trying to get you to do is be inspired, a little bit enthused, perhaps reignite, if not ignite, a passion for surgical research. And so my aim really is to empower you to be inquisitive, to get you to challenge, question, and the accepted norms, and to promote a broad research ethos in your day-to-day surgical practice. So the boring stuff is that the NIHR, the research academy arm, if you like, of the Department of Health, defines clinical research as a way of understanding the cause of human illness and how it can be treated or prevented. That's fairly obvious. It can be observational, can be comparative. We can use scans, population data, and surveys and health data. And we're all pretty comfortable with that, I think, as a concept. And similarly, we're all comfortable perhaps with that. Those that gain from research are pretty broad. Patients, clearly, because they get excellence in terms of care and up-to-date treatment rationales. The NHS gains because perhaps they get more cost-effective interventions employed with improvements in health policy. Clinicians, we all get to try out new kit or advance novel therapies. Researchers, they grow their portfolio, higher institution gains, and industry in terms of collaboration. But these are all pretty standard definitions of why we all should be involved in research and why it's important to us. But the question I pose perhaps is there more to surgical research that should inspire us and make us think a little bit that it's more than just plan A versus plan B? Before we do that, I just thought I'd interject every now and then with a quick quiz. So does a negative pressure help wound healing for open fractures? So open fractures, putting negative pressure on dressing versus standard care. So negative pressure, who votes so it would be better for wound healing? Okay, good. Some of you read some papers maybe. And then the rest of you who don't. So the rest of you were in fact correct. So they took 300 patients and compared them to 300 in each group and demonstrated that negative pressure made no difference to the outcomes for both disability, healing, and deep-seated infection. So that's an obvious one, why we should all not use negative pressure for open fractures. I'm not a fracture surgeon or orthopod, but there's similar trials showing similar results in diabetic foot disease. But let's bring it to patient safety. So we're all familiar with a version of this. This is the WHO Surgical Safety Checklist. And we do it as part of our checks. And if you do a day case list, you'll do 20, 30 of these in a day. But, it's an integral part of what we do since 2009. But the background to all of this is actually surgical research. So in 2009, there was a study conducted about 4,000 patients, and they demonstrated across a number of healthcare settings in Canada, India, the UK, Philippines, and Australia that there were dramatic reductions in all complications just by introducing a surgical checklist. There was also dramatic reductions in death. There was reductions in unplanned returns to theatres. And so through this surgical research, a very simple tool has shown benefits in outcomes. If we examine that further and check in on the checklist, this is a really cool paper. If you've got time to read it, it's worth looking at. But they demonstrated that not just in the UK, the US, Australia, and Scotland, but there was sustained improvement in these outcomes. So therefore, at the point of introduction through to now, we are still seeing the benefits of the WHO Surgical Safety Checklist in our day-to-day practice. So that thing we take for granted at the beginning of the list is fundamental surgical research. So I might add that surgical research improves patient safety. So although we don't think we are all participating research, we're not merely passengers here. We're implementing surgical research every day. Quick quiz number 2 then. Does butcher's broom Ruscus extract help with venous leg symptoms? So here's a bottle of the tincture there that you can get, and you take that to help with edema, swelling, aching, heaviness. Any thoughts? Who votes that it does help with venous leg ulcer symptoms or venous leg symptoms? Yeah, it's kind of a leading question, but there's about 4 of you. Okay, brilliant. But it did, in fact, yes, it's significant improvement. So across a systematic review of 10 RCTs, there were 10 RCTs in this area, of thousands of patients, it demonstrated to help with venous symptoms. And it's incorporated in the ESVS guidelines, and so it's part of my practice in venous care. So, again, implementing guidelines, but implementing in practice. Another obvious reason why evidence and research is important. A little bit cooler then, this video should be playing. So this is a VR helmet. There's lots of ours out there. I have no disclosures, apart from my son has bought a Meta. But anyway, this is training of the modern era. So this is virtual reality headset, putting pins in knees and doing something orthopedic to improve the training experience for trainees. That's actually been developed into a research project and research portfolio. And the same group have gone on to demonstrate that novice participants trained using VR versus those using other types of training, so guidelines, textbooks, and simple diagrams, had the VR trainees had a significantly better outcome in terms of time, if time was a success, but also less different pinpointing of the pin in and out. They were more accurate, and also the overall procedure was more efficient. So although research is often thought about pathway A versus pathway B, or treatment option versus A and B, this is surgical research in action to enhance our surgical training to make us better surgeons. The same thing happens with simulation. So if you look at laparoscopic surgeons, again, there's loads of evidence in terms of laparoscopic training, both bench models or VR-based, improving training time, improving transfer to the OR, so not just doing it in principle, but actually the operating room environment, the communications, the reduction in errors, reduction of opening the wrong piece of kit, the wrong size of kit. And the same in endovascular procedures for vascular surgery. It mirrored into the operating environment and improved our training experience in a shorter frame time. So this is surgical research affecting all of us in surgical training, even post-CCT going to develop skills. There's TVAR training modules for thoracic grafts. So in terms of in the critical environment, simulation training's worked again. Did I click through? Yeah. In the simulated environment. So if we go into emergency systems, so we're looking at time critical environments in ruptured aortic aneurysms, there was evidence that shows that if you simulate that environment over and over again, when you implement it into clinical practice, you improve the outcome for the patient. Not just how well we speak to each other, not just how quickly blood gets to theatre, but actually you improve a lower mortality, with significant reduction from about 40% to about 25%. And that's just on the simulation. It doesn't matter how well, it's not just about putting the stent graft in the right place, yeah? So this is how surgical research improves not just our simulated training, enhances our education, but also improving patient outcome. So perhaps not what we think of when we think of surgical research, but something we're all engaged in all the time. So quick poll number 3. This is huge closer technique. Perhaps a professor from the 60s. Sorry, I didn't get further than that looking into it, but has a technique in the mid-2000s versus standard mass closure. Is this technique, using a much more intricate mattress technique compared to standard mass closure, better or worse? Or better? Better for Hughes' technique? Better, 1. Maybe you all know this already. But the point is that there was a randomized control trial which was funded by the NHR that reported in 2019 that demonstrated that actually it made no difference across 802 patients. Yeah. So there was no statistical reduction in the incidence of 1 year incidence of incisional hernias. So again, implementing the ideas that we had, putting them into a trial, testing a hypothesis, and comparing outcomes. So that's more of the obvious aspects of why clinical research is important, but something you're all probably doing every day, or most, or some of us. Okay, this is a little bit more perhaps interesting. So what we've got is the papers, the landmark papers, basically demonstrating that female surgeons have better surgical outcomes than male surgeons. The landmark paper in JAMA a couple of years ago, 2023, was about 1.5 million patients, of which about 150,000 surgeons were operated on by women, so or surgeon sex being female. So those outcomes of those 150,000 patients were better than the other remaining million surgical outcomes by the surgeons that were male. There's a broad aspect of surgical procedures. It was repeated on a multi-study basis, on a systematic review, so there were 5 million patients now included. And again, the outcomes were that surgeons' sex made a difference to the outcome of the patient. So what do we learn from that? Well, what can I learn from my surgical counterparts? That's the first question. We've all been on the ward round where I've been the reg and the consultant has been ignored by the patient. So can we break down some barriers in terms of stigma for having a female surgeon or having female colleagues? Can we improve our workforce retention, recruitment to surgery? Luckily, I work with 4 vascular surgeons who aren't male, so it's fantastic, but that might not be representative of where you work or where the environments you work in. But again, an example of research that is driving change and improving the outcomes for patients and for the workforce, and retaining people and getting people, translating that high number of medical students that are female into high number of surgeons that are female. If we take that a bit further, we look into diversity and equity, surgical research branches into that field as well. There's a whole load of papers that were published very recently in the States demonstrating that in terms of surgical leadership, academic surgical leadership, chairs, surgical society leadership, has yet to translate from ethnic diverse workforce into the ethnic diverse leadership. And that transition in terms of workforce is huge. 40% of the NHS workforce is non-Caucasian or white, yet the leadership and the management systems don't reflect that. Now, maybe that's time, maybe it's not. But the whole point of this research is to get us to think about that, ask those questions, and understand perhaps why. In fact, the Royal College of Surgeons of Edinburgh have gone a step further and asked about black surgeons in the UK. And actually, their research has demonstrated that only 2% of consultant surgeons are black, compared to 34% being Asian. So, there's big differences in numbers when you're looking at equality and diversity in our workforce. But another example of surgical research, perhaps going beyond what we perhaps thought about in terms of A versus B. Yeah? So this is all surgical research and all for the benefit of improving care of patients and the environment that we work and live in. Some of the groups that have done this are looking at our ENT and ophthalmology surgeries, have demonstrated that these differences can be overcome, and perhaps there are things to discuss and providing equitable opportunities amongst surgeons in the UK. Okay, quick quiz number 4, quickly if I may. Can we, for anemic patients, before major abdominal surgery, should we give them intravenous iron to correct their anemia and reduce the blood loss use, reduce the use of blood? Very topical, blood loss. There's a crisis at the moment in terms of use, or at least there was. Who thinks we give iron, it's going to make the blood loss reduce, right? Incorrect. So, sorry. There was a randomized control trial, NHR funded, which reported in 2021, which demonstrated that there were, across 500 people or so, major abdominal surgery, there was 111 versus 105 transfusion rates if you gave iron or not iron. So maybe it's the procedure and not the iron, maybe it's not the anemia, but that's something to discuss. So what we thought we knew, i.e. we give iron to everybody, will make a difference. Maybe we didn't know, it changed our thinking. So the animation's got a bit messed up on this next slide, but anyway, here we go. Moving on to another area, carbon footprint in surgery. Very topical, all driving electric, got solar panels, heat pumps. I haven't got a heat pump, I'd love a heat pump, but anyway. In reducing the impact of surgery in terms of our carbon footprint. So this is all surgical research, a Delphi process, a green surgery port, carbon neutral hand surgery by using a single-use kit, and then looking at disposable and single-use in cataract surgery. Again, all surgical research, enhancing the care we provide, in providing care for the environment. The impact is broader than just outcomes for patients. So whilst we might not think it's doing an MD, as we talked about serum rhubarb versus this, actually this is surgical research and it's applicable to everything that we do. And so that's really my message, that's demonstrating the importance of surgical research far beyond even than A versus B. Not to say that isn't important, which is why we've interspersed the quizzes. So it's not just A versus B experimentation and hypothesis testing, although that's a critical part of it. It all makes a tangible difference to our day-to-day practice. And there's a huge breadth of surgical research. Much of it I still haven't even touched on, but they're just some of the flavours that come out in the literature and in what issues that matter to us in our workforce planning. It would be wrong of me not to mention surgical research without recognising the importance of partnering with patients and patient groups. So if in doubt, ask one of the charities that you work with, ask one of the James Lind Alliance organisers or prioritisation exercises if your research might be something that aligns with those, because you've probably got a fantastic idea. Someone else in terms of patient may have experienced that, and you can partner with those to answer a question. And there's a couple of things to close, is that the impact of surgical research is beyond treatment A versus B, yeah? I want you to think about it more about the impact of everything you do. So why we do the WHO checklist for me was one of the big questions when I was asked by a trainee, God, isn't this a waste of time? But, you know, they've woken up and their limb must have changed, and, you know, they've woken up, their identity hasn't changed, you know. But actually, it's a really fundamental, important part of what we do. The future I haven't even talked on is AI, so there's things like that coming into research, and hopefully that promotes a culture amongst all of us of research engagement. So not just recruiting to clinical trials, but engaging and implementing that research that you see and participate in. So take-home messages: be inquisitive, challenging and question the accepted norms, and if you don't know the answer, go and find out, and if someone else hasn't got the answer, maybe you're onto something. Build a broad research ethos into your day-to-day practice that is beyond what we traditionally think of, and maybe is much more integral to everything we do than we thought yesterday. Thank you for your time.
Sandip, that was very interesting. Thank you very much indeed. I was going to ask, how many of you have published a surgical paper in a peer-reviewed journal? And how many of, that's nearly everybody, and how many of you have taken time out from your clinical practice to do a period of research, just focusing purely on research? That's about half of you. So that has changed, hasn't it? Would you, I'm going to ask you a few questions about research now. Would you recommend taking time out or would you recommend building research into your clinical practice?
Yeah, so I confess when I set out this talk, it's more to try and inspire that research is far-reaching. But I did, over an open aneurysm, one day when I wasn't quite sure what I wanted to do for a career, was offered a research job. So I took time out and did a research degree. I would encourage you to think about it. And it isn't for everybody. There were dark days when I was looking through the sort of options of maybe even being a pilot, looking at other careers I might do whilst trying to recruit patients into my own trial. But it certainly opened doors in terms of opportunities, discussions. You become very knowledgeable, very small area within your specialty, and that makes you a resource to your colleagues and others.
What was your research into?
It was into varicose veins. Yeah.
Everybody's got varicose veins.
It's into varicose veins, yeah. So I ran 2 RCTs.
Nobody can get them treated.
We can in Newcastle, but yes, but no, varicose veins research. But it just opens doors to you thinking a little bit more critically. For instance, why we do X, Y, Z on a day-to-day basis. Should I use betadine? Should I use Chlorhex? Should I be, if there isn't evidence for a drain, why isn't there evidence for a drain? Should I use a drain? Should I not? You know, just because somebody always tells you to do something doesn't necessarily it's either right or wrong. And so for me, it just made me a little bit more inquisitive.
I can't imagine anybody who'd want to do research into varicose veins. Can you, Miss Winterbourne? Question. Roberta.
Thank you very much for your talk. I'm a kind of clinical academic, so doing a PhD, dying breed of research in a lab, unfortunately. Do you think, we know there is a crisis in clinical academia in the UK, surgical academia as well. What do you think is at the root cause of that? How do you think can people like me who are doing a PhD well supported can then progress to the next stage? Because there seems to be almost no chance of progression to the next stage at the moment for people from my generation. So how do you think it should change?
Yeah, so great question. So there's the integrated academic training schemes, which are the gold standard or the pathway of training. So you do F1, then IAT in terms of ACF job, then you do your doctorate degree and so on. But I didn't do that. And many people in the room will have been where they are now as a symptom of fortune and opportunity and just because they ended up there and that's how it worked out. So I don't think it's always something you can necessarily plan, but there are key steps you can make. So I think the door close on post-PhD life is probably not quite. I would encourage you to think about the NHR ACL program. So after your doctorate job, I think about going for a clinical lectureship. We are a little bit disadvantaged in that some of those jobs are pre-assigned, so it is competitive against 2 other specialties. Usually it's grouped in 3s. Go and meet peers. What specialty do you do?
I do colorectal and I'm in Scotland. So.
Okay. So are they not available in?
No, we get time out, but it's 20% of your training, and it's more thinking about, once you become a consultant, it's at the moment for my generation, it's very hard to go to a kind of intermediate or senior fellowship.
No, I agree with that. I mean, I got a fellowship after CCT, and then now I've applied and got another one. But the challenge, there's a real challenge. I get it, and I think 20% academic time is not enough. Most surgical jobs are maximum a kind of 50, or the NHR wants you to do 40% clinical, not 50%. So it's still striking that balance, and I think that's a difficult one. For me, it was just going out and finding what was there. Some of the universities have their own schemes, so we have an academic health sciences network, which sometimes may offer posts to you, but they are competitive, and it is a real shame. It's a dying breed, but I'd just be tenacious. That's what I would do. Just keep going and go and ask the uni, what is the possibility of this, and how might I scrape together funding for it.
Derek, you've got a comment.
I have enormous sympathy for you, because this is a real problem in the UK system, and this is why I was harping on about getting to understand the system. If you begin life at an early stage in an academic pathway, you can progress in an academic pathway. It's very difficult to get out of it, though, into the non-academic pathway, because people label you as being an academic and they think that you are a certain type of creature. It's wrong, but that's what happens. And exactly the same is true of the opposite side. If you do not start in an academic post and work towards a PhD, you're not likely to gain an academic post with a university. Those are fundamentally wrong, but they are fundamentally, at the moment, part of the UK system. It's not like that in other parts of the world. And there's no reason to perpetuate it, other than the fact that it's convenient for administrators. But I'm sorry, it shouldn't happen, but it does.
I mean, the Green Shoots Awards. So there are Green Shoots Awards. So where you can apply for 1 or 2 sessions as a step back into research. So if you came out and didn't have a CCT job that was academic, you can then apply for those, and that gives you time, which you can build into funding awards for your time.
Yeah, another question.
So I completely agree with what Prof. Alderson is saying in terms of Roberta with the set routes of being an academic and maybe not an academic. My story was that I was trying to juggle the plates, and I kept being repeatedly told I was missing the research plate. So then I started to look for research opportunities, not necessarily as an academic, as we all know it, on the academic pathway, but just trying to get that taster. Like you mentioned, it's important to understand how to critically appraise, things like that, basics. I was repeatedly finding that it's so hard to find that. You've either met with bosses who have no interest in research, so they don't want to help you, or they're so interested that they have PhD fellows who are already doing it, and I was really struggling just to get the basic understanding of how research works without putting myself in a set pathway. Have you got any advice about how to navigate that?
So I get a lot of requests in the same. So a lot of our trainees, vascular or otherwise, they say, have we got an opportunity to get on something? Can I get a post? Can I get a presentation? I would go to your unit and find the academic lead, because that's definitely a good way in. For me, it was also low-hanging fruit. So every project I undertook at a CT or an ST level was to try and see where I could change something, where the implementation was going to come. So it isn't just about doing that audit, but is there a national guideline, a James Lind Alliance, something that you can tie in that idea to? And it can be really simple. It doesn't have to be groundbreaking, writing a paper for the first time. It can be a project about the implementation of a guideline into real world practice, because that is research of how you can translate the guideline and the evidence into quality outcomes. So finding somebody who's motivated is hard, but often the people who are motivated are busy. But again, I would just be tenacious. For me, it was just keep asking, keep pushing, get to the things. There's a lot of pump priming awards. So, for us in vascular, there's the Dragon's Den, there's Royal Society of Medicine in terms of the Venous Forum. So there's a lot of pump priming awards that might give you a little taste. BSETs and in British Society of Endovascular Training for us. So there'll be the equivalents in your specialty, in your domain. that will give you seed corn funding, if you like, for an idea. But don't take it as like, I've got to get a name on a paper and then tick the box as CTT. What I think is more important is this culture of research is part of everything we do. And whilst I can come at it from a trial point of view and a grant that I've got for A versus B, that's great. But the person on the coalface is actually wanting to know, how can I digest that information to make my practice better? And that's what all that was about, to try and show you that even though you think that research is A versus B, your idea on, I don't know, how to get greater recruitment from medical student into surgery of your specialty, that is research in itself, and that will make a difference at some point. So it's not being afraid to think outside the box for an idea, really.
Celia.
Thank you. I was going to comment that, as you highlighted, you don't have to commit to a high degree to appreciate evidence-based medicine. There are some specialties, vascular surgery and general surgery, where the proportion of people that commit to a high degree is more than 80%, whereas for most other surgical specialties it's down to 20 or 30%. My question was, if you do commit to conducting research towards the award of a high degree, how much time should you take out of training? Because 20 years ago, most people were an MD, they were 2 years out, but still doing on-call and hands-on clinical practice. Whereas now the applications that are coming through are for a minimum 3 years, and some people even 4 years, and that's outside of the sort of integrated clinical academic pathway. So what do you think?
Not sure I'm long enough in the tooth to answer that, but for me, it's a balance between the project and you as a person. So how long do you think you can, if you find this as a labour of love, that's easy, because you can go into it, enjoy it, and come out of it. But some of it is, you have to be quite motivated, driven and determined. And if your bandwidth and your strength in depth doesn't match that, then you might find yourself coming unstuck, going for too long. The other fear that a lot of people say to me is, but if I do this MD, I'm not going to be able to operate. And I think we've already talked about that. It's about the pace of life in terms of the situation you're at. So for me, I knew that those times I wasn't doing any clinical work apart from recruiting to varicose veins and a few laser veins. But I knew that my appendix and my other numbers weren't going to be progressed on. So it's accepting that. And it is something you can learn again. There is a muscle memory. And let's be real, the practice that you had as a CT2 versus what I had as an ST6 is wholly different. I thought I could do an appendix, but actually, when it came to going back into ST3, I probably really learned how to do it. So I think it's a balance for you. It's personal, the project, and your passion for it going forward. I think I don't think there's a right time or right answer for that.
That's brilliant.
Yeah.
Thank you
Thanks.
very much indeed.
No, thank you.